I've never taught my students anything. I just try to put them in the best conditions to learn. Albert Einstein. Ladies and gentlemen, welcome to the fourth webinar series, Diapath Lab Talks 2022-2023. Diapath is an Italian-based company successfully providing high-quality solutions to pathologists, lab scientists and lab professionals all around the world. Today, Diapath is a fast-growing company with a worldwide presence, counting on a network of dealerships in more than 90 countries, providing both commercial and service solutions. We offer a complete portfolio of solutions for the anatomic pathology lab, including 868 products. We are eager to get in touch with you. Register to our live virtual demo, search and choose any Diapath instrument from your lab, and book a live demo with our specialists. Not only products and solutions, we are there to empower pathologists and lab professionals, sharing the best ideas. Join diapathlabtalks.com, the connecting hub with a complete range of scientific articles, webinars, training resources, a state-of-the-art blog, and podcasts, hosting interviews with opinion leaders and experts. Diapath is approved CEU's provider by NSH, National Society for Histotechnology. Please follow the instructions under the website www.diapathlabtalks.com. Diapath Lab Talks include 4 webinars. Before starting the webinar, just some practical information. The webinar is about 30 minutes. Then we are going to have a question and answer session at the very end of the webinar. So you are kindly invited to have your questions at the very end, typing the questions in the chat for the final open discussion. Thank you.
Hello everyone, thanks to Diapath and especially Dr. Antonella Savio for inviting me to participate in this Diapath webinar talks. My topic today is about sarcomas and especially in what do we need to reach the diagnosis. Soft tissue and bone sarcomas are really a diagnostic challenge for several reasons. There is a heterogeneous group of rare malignancies. They constitute around 1% of all cancers. They may appear at any age, any location, and there are between 70 to 100 different histological subtypes and tumor entities. There is also a morphologic overlap, and I will comment this in a moment. We have to deal with limited biopsy material. There is obvious divergent pathological interpretation, like in other areas, and in the end, both rarity and heterogeneity affect diagnostic accuracy. This is part of the last WHO classification that was published in 2020, and there are many new entities that are indicated by arrows. In fact, in this new classification, the small undifferentiated small round cell sarcomas were better delineated, and there are as many as histological subtypes as varieties of fruits. So here in this list, these are the tools that we use to reach the diagnosis, and I will comment a little of each in the following slides. And let's start with clinical and radiology data, which is essential and especially or is mandatory in bone tumors. Age, symptoms, site, size, previous history of cancer or radiotherapy are very important to know to reach a proper diagnosis, as well as different associated syndromes, and also important is local staging before biopsy. And at this point, I would like to show you some examples of how important is clinical data to reach the diagnosis. On the left, you see spindle cell neoplasm with some sort of mitotic activity and scattered giant cells. This could perfectly be a low-grade spindle cell sarcoma. In the middle, you see another lesion composed with immature bone formation. It seems that the cells are not very atypical, and this could be an osteogenic tumor. And on the right, you perfectly see a spindle cell sarcoma with cellular atypia and bone formation. So this could be a kind of osteogenic sarcoma. If you pay attention to the FISH results, you see that the two first cases show USP6 gene rearrangement, and the third case shows MDM2 amplification. Okay, but we know that USP6 may be rearranged in several entities such as myositis ossificans, nodular fasciitis, or fibroosseous pseudotumor of digits. In case of MDM2, this gene may appear amplified in several entities such as D-diff liposarcoma or low-grade intramedullary osteosarcoma or even parosteal osteosarcoma. So we have the morphology, we have the FISH results, but we don't know exactly the exact diagnosis. So we will back to these cases at the end of this presentation. For sarcoma diagnosis, I mentioned before, we have to deal with small biopsies. The core needle biopsy, in fact, is the standard method for the initial diagnosis of musculoskeletal tumors. This kind of biopsy should answer these questions. Is the lesion mesenchymal? If mesenchymal, is it benign or malignant? And if it is malignant, what type of sarcoma is it? So the histotype and grading when possible. Once we have looked at the biopsy, we start thinking about different diagnoses according to the cell morphology, especially to the cell morphology and the kind of matrix or stroma. I will give you some examples. If the morphology corresponds to a spindle cell, we can start thinking about a lot of entities that look like spindle, ranging from benign to malignant tumors, nodular fasciitis, schwannoma, solitary fibrous tumor, which is an intermediate malignancy, to frankly malignant spindle cell sarcomas. Let's go back to the morphology. If what we see on the biopsy is a small round cell tumor, our mind changes to another differential. This differential could include from Ewing sarcoma, any undifferentiated small round cell sarcoma, alveolar rhabdomyosarcoma, and so on, including lymphoma, neuroblastoma, and small cell carcinoma if it occurs in adults. At this point, I would like to point out that small round cell tumors appear mainly in children and adolescents. Usually, these are high-grade tumors by definition and also are often translocated sarcomas. So molecular pathology probably is very important in this kind of tumors. Going back to the morphology and regarding the kind of stroma, we can find myxoid stroma. If this is the case, we can do another broad differential between many entities that may show myxoid stroma, ranging again from benign lesions like myxoma to frankly malignant tumors like EMC or myxoid liposarcoma. We should try to give a histological grade on the biopsy. Histological grade, as you probably already know, indicates tumor aggressiveness, is the most important independent prognostic factor and is a guide for treatment. That's why it's so important. In sarcomas, histological grade is part of the staging system. So to perform TNM, the grade is included. The most used grading system is the French grading system, and it uses 3 histological parameters: tumor differentiation, number of mitosis per 10 high-power fields, and percentage of tumor necrosis. You see here on the left, grade 1 to spindle cell sarcoma, and on the right, a high grade 3 sarcoma with pleomorphism, necrosis, and high mitotic activity. It should be noted that sarcomas are heterogeneous. So when dealing with a small biopsy, if the needle falls in the gelatinous areas, like in this myxoid liposarcoma, we can see a low-grade myxoid liposarcoma. If the needle falls in the fleshy areas, then we can see a high-grade myxoid liposarcoma with round cell component. So it's very important to know that with this kind of material, there is a possible underestimation of the histological grade in core needle biopsies. So we have to be aware of that, not only the pathologists, also the clinicians. Well, when morphology is not enough, then we have to integrate an immunohistochemical panel. Which is the role of immunohistochemistry? Well, we have 4 different scenarios in which immunohistochemistry is very useful to reach the diagnosis. The first is differential diagnosis between mesenchymal and non-mesenchymal tumors, and I will show you 2 examples. Second scenario is the standard method for establishing the line of differentiation. For example, if you think about a spindle cell tumor and we want to know if it is vascular, neural, smooth muscle, etc. The third scenario is when is useful for the differential diagnosis and classification of a spindle cell or round cell neoplasms. And the fourth, and very important, the last years, is that immunohistochemistry is useful to correlate with molecular genetic alterations, and I will show you also some examples. In these pictures, on the left you see a leiomyosarcoma, and on the right it is H. caldesmon, which is a smooth muscle marker and is very useful to recognize smooth muscle tumors. These are 2 examples of how immunohistochemistry can differentiate mesenchymal versus non-mesenchymal tumors. On the left, both are spindle cell neoplasms, but on the left you see this is the skin, and under the epidermis there is a spindle cell neoplasm with frankly atypical, and the immunohistochemistry shows cytokeratin positivity, which means that this is not a sarcoma, but it is a spindle cell squamous cell carcinoma. And on the right, again, spindle cell malignant tumor, which is strongly and diffusely positive for S100 and corresponds to a malignant spindle cell malignant melanoma. So very important, especially if you are looking at skin biopsy. Once you see a spindle cell atypical lesion, you have to rule out a spindle cell squamous cell carcinoma or melanoma before giving a diagnosis of sarcoma. Another scenario, established line of differentiation. You see here, this is a case of a female, 63-year-old, a gastric wall tumor. The first diagnosis is GIST, just because the location, and in fact this tumor was a spindle cell tumor, but CD 117 or c-KIT was negative, and DOG1 was negative as well. Only S100 was positive, and this was not a GIST, this was a mesenchymal tumor with neural differentiation consistent with gastric schwannoma. So it is very important because, as you already know, the treatment is very different. Another utility of immunohistochemistry is classification of spindle cell neoplasms due to the morphologic overlap, as I mentioned before. Here you have a synovial sarcoma on the left and MPNST on the right, and really they look like very similar. It's true that we have some morphological clues to differentiate these tumors. For example, microclassifications are typical of synovial sarcoma, perivascular accentuation are typical of MPNST. But many times these morphological clues are not enough to do the differential diagnosis, and then immunohistochemistry may be very helpful. So we usually use panels, not only one or two antibodies, different broad panel of antibodies to make this differential. The same with the small round cell tumors and epithelioid tumors. The fourth scenario is the one that have developed a lot the last years, and is the use of immunohistochemical markers as surrogates for molecular genetic testing. It means that the antibody is a surrogate of an underlying molecular alteration. We can find gene mutations like beta-catenin in desmoid tumor, mutation of H3F3A in giant cell tumor of bone, and etc., or gene amplification with MDM2 antibody, or MYC in secondary angiosarcoma. Deletions, for example, loss of a smart CB1 in epithelioid sarcoma, and the ones that are very useful, like STAT6 in solitary fibrous tumor, CAMTA1 in epithelioid hemangioendothelioma, NTRK, FOSB in epithelioid hemangioma, and so on. I show you here one case of a 27-year-old woman with a posterior right thigh tumor. The diagnosis was alveolar soft part sarcoma, as you see here. We know that this tumor has this fusion gene, and we can detect as a surrogate the TFE3 fusion gene by this immunohistochemical marker of TFE3. Sometimes the molecular finding, the fusion gene, was discovered before the antibody marker. So the antibody appeared later. Okay, when morphology and immunohistochemistry is not enough, then we have to resort to molecular pathology, and we have to integrate genetics only when necessary. Perhaps fluorescent in situ hybridization, FISH, is the technique most used nowadays, but also PCR and NGS, or next generation sequencing, that I will comment a little bit more. The usefulness of NGS is that we can study several genes at the same time. So it would be especially indicated in those undifferentiated tumors in which it is necessary to perform more than one FISH or PCR technique to reach a diagnosis. So now I would like to show you some examples of the use of molecular techniques, either FISH or NGS or PCR, in sarcoma diagnosis. So what we use in clinical practice. This is a situation that is very not uncommon, and is used on then MDM2 amplification by FISH to differentiate differentiated liposarcoma from a lipoma. Is especially indicated in deep lipomatous tumors more than 10 centimeters in patients more than 50 years, recurrent tumors, when we find equivocal cytologic atypia, location in the retroperitoneum, pelvis or abdomen, and in any spindle cell sarcoma in the retroperitoneum, doesn't matter if it has a lipomatous component or not, to rule out a D-diff liposarcoma. Here is an example of the huge lipomatous tumor in the buttock. You see here the atypical stromal hyperchromatic nuclei between the fat cells, and here on the right you see the MDM2 gene amplification. This is another situation in which use the molecular pathology. It's confirmation of a sarcoma in an unusual clinical and morphological context. This is a case of a 63-year-old with a mediastinal mass. Morphology looks like myxoid liposarcoma, but there are some atypical cells that don't exactly fit with this diagnosis. If we perform FISH for DDTI3, which was positive in this case, it confirms the diagnosis of myxoid liposarcoma. You have to know that this is an unusual location, unusual age, unusual morphology. So in these cases, molecular pathology is indicated. Another case, differential diagnosis between undifferentiated small round cell sarcomas. I would say that this is one of the main indication for using molecular techniques. This is a 12-year-old boy with multiple intra-abdominal masses, as you see here in the CT scan and the macroscopic appearance. This is, in fact, a small round cell tumor in a desmoplastic stroma. This tumor showed polyphenotypic differentiation by immunohistochemistry with positivity of WT1, cytokeratins, and desmin, and FISH showed EWS-R1 gene rearrangement. So should we call it Ewing sarcoma? Just because we see this rearrangement of this gene, you should call it Ewing sarcoma? Of course not, because we already know that there are soft tissue tumors and bone tumors other than Ewing sarcoma carrying EWS translocation. And we have to be aware of that, because these tumors may be even benign tumors, intermediate tumors, and fully malignant tumors. So in these cases, we have to better perform NGS, because we can see the EWS-R1 gene and its partner, and we can reach the specific diagnosis. So in this case, we perform NGS, and the fusion gene was with WT1, and the diagnosis was desmoplastic small round cell tumor. Molecular techniques are useful also for diagnostic confirmation in complex cases like this one. This is a 45-year-old in a tumor in the maxilla. The H&E slides showed a spindle and epithelioid malignant tumor. Here you see the oral squamous mucosa with rhabdomyoblastic differentiation. And this tumor, in fact, corresponds to a subset of rhabdomyosarcomas that show this kind of fusion gene, FUS and TFCP2 fusion gene. Very rare, recently described, but the only way to reach a specific diagnosis in these cases is using the NGS probes. Another utility is confirmation of a sarcoma when histological, immunohistochemical, and some sort of molecular features doesn't fit. This is another example. 46-year-old female with a left side soft tissue tumor. I must say that morphology is perfectly consistent with a high-grade myxoid liposarcoma. 30 years ago, probably we didn't do anything else. But in this case, in myxoid liposarcoma, we know that the fusion genes are DDTI3 with EWSR1 or FUS genes. So we tried to find the DDTI3 rearrangement by FISH, but it was negative. It was really a surprise. Then we continue with the study. EWSR1 was positive, but this result is a little bit confusing, and we confirm the diagnosis with NGS that showed this fusion gene typical of myxoid liposarcoma. Another scenario is prediction of treatment response, and the paradigm is GIST, clinical uses for GIST genotyping. In this case, molecular techniques are useful to confirm the diagnosis in those cases that immunohistochemistry of a suspected GIST is negative, but it's also critical to make a clinical decision in several settings, meaning that depending on the mutation, the patient can respond or not to imatinib therapy. So this molecular study has prognostic value, and it should be included in the diagnostic workup as a standard practice. Finally, we know that molecular techniques may allow to find target therapies like this big list, and it's very helpful for clinicians. So this is what we call nowadays precision medicine, to find the exactly diagnosis and the exactly segment for the patients. However, molecular pathology has several limitations. There is a genetic overlap. We can find same genetic alteration in unrelated entities and tumors of different lineages, sarcomas, low malignant potential soft tissue tumors, even carcinomas. So we have to evaluate in the morphological context. Always evaluate the results of molecular pathology in the morphological context, and I will show you some examples. We may find ALK fusions in inflammatory myofibroblastic tumor, but also in anaplastic large cell lymphoma, nothing related, or even in an epithelioid fibrous histiocytoma, which is a benign tumor. Another example, this fusion gene ATV6 and TRAC3 in infantile fibrosarcoma, but also in secretory breast carcinoma, even in some kinds of glioma. So this is really a limitation that we can avoid if we evaluate these cases, as I mentioned, in the morphological context. So let's go back to the beginning, and now I will show you. I will demonstrate you how clinical data is so important. Remember the cases I showed you at the beginning of this talk: low-grade spindle cell sarcoma, osteogenic tumor, and osteogenic sarcoma. So I mentioned the results of the fish that weren't definitive for the diagnosis, but if we know, for example, that in this case this is a superficial tumor attached to the fascia in a 9-year-old boy with rapid growth, we can make the diagnosis of nodular fasciitis with the USP6 rearrangement. The case in the middle, if you know that this patient had a trauma 2 or 3 weeks ago, and we see on the images this peripheral eggshell calcification, we can make the diagnosis of myositis ossificans with the same USP6 rearrangement. And the third case, if you know that this tumor is a huge retroperitoneal tumor with some kind of lipomatous component, we can make the diagnosis of DDIF liposarcoma with heterologous, in this case, osteosarcomatous component. So just with the clinical and radiological data, we can do the specific diagnosis. So at this point, to respond to the question that what do we need for sarcoma diagnosis, I would say that we need all of the tools that I have mentioned in this talk, but just some remarks. Conventional morphology, H&E, and clinical data still is very powerful and are essential tools. Integration with immunohistochemistry is a diagnostic standard. Molecular genetics is helpful in increasing situation, but only in context with morphology, and never is a replacement of morphological and immunohistochemical diagnosis. Perhaps FISH is nowadays the most affordable and currently used test, but there is an increasing role of NGS for both diagnosis, prognosis, and therapy. And this would be the workflow for sarcoma diagnosis, from the patient through the biopsy, morphology, H&E, immunohistochemistry, and molecular pathology, and to reach the final diagnosis. And also, always remember that this effort must be supported by a multidisciplinary team that includes radiology, pathology, molecular biology, and the other clinicians. And this is the most important thing, the patient with sarcoma. Thank you very much, and I will be delighted to answer any questions you may have. Thank you.